Hi guys, good evening. Hope all of you are doing good. First of all, sorry for a little delay. I mean, as they say, when we were ready with it, but there was a technical glitch. That is why there is a little delay which happened. I hope that uh, now you're able to see me properly and you're able to listen also. Please let me know if everything is okay. Uh, they say when life give you cactus, do not sit over it, and you have to find out the ways to get out. So there was a glitch. We had to shift, and that is why there was a little delay. I'm very sorry for that. Your time is very precious, and on behalf of entire team MIST, me, myself, Dr. Kunal, I welcome you for the 25 most important pathology question session. Now, in this session, how we are going to go about, I have taken clinical questions, 25 clinical questions, and we would be having some images as well, which we'll be discussing, which are spotters directly, which I feel that if you see those images with any question, then also there should be no doubt in your mind that what exactly is this image, and there would be certain things, some one-liners, few one-liners which I feel which are important for you. Now, there's a sea of things which can be there in pathology, because pathology is associated with everything happening inside. So, but then the only focus here is for your FMGE exam, which is going to be on 4th of December. And I would not be wasting any further time. And good evening to all of you. Ikra, Fazil, Rahitash, Anjana, Kalpana, Altaf, Devraj Singh, Akhil, good evening to all of you. Now, let's see the first question. Okay, before the questions, this was the amount of questions which we have got in the last 3 exams. And in the last 3 exams, if you look, like in the June 2020, the last exam which we had, pathology, as you know, is divided into 3 parts. So general path, hemat, and systemic path. Now, this is all about the recall which the students have given us. So if you talk about the recall, general path had 8 questions. Then hematology, from there in last session, there were 7 questions and 8 questions from systemic path. Total amount of questions were 23. Then in December, the total amount of questions were 25. And in June, the total questions were 23. So more or less, if you see every system, the parts of pathology, they are important. So we would be taking care of all the systems here, and I will be giving you questions on every part, so that and the topics which are very frequently asked in the exam. Okay. Now, yeah, good evening, everyone. Thank you for being here, and I'm really very sorry for a delay. Now, the question number 1. Now, these are long questions. Whenever you get these kind of questions, my humble advice to all of you: do not hurry in marking the answer. Read the question properly. Whenever we are seeing the long question, the last line has to be read first. So in this, if you see the last line, what they are asking, they are saying that comment on the serum calcium level of this patient. So basically, we are talking about the calcium levels. Now let's read this question. A 48-year-old chronic alcoholic with history of hyperglycemia came to the nephrology department with complaints of oliguria and bone pain. Upon further evaluation, the HbA1c was found to be 8.8%. Okay, that means the person is really having uncontrolled sugars. Creatinine level is 2.7 milligram per deciliter. That means there's way high creatinine which we are seeing. And the GFR is 38 millimoles milliliter per minute. So GFR 38, that means the patient is already coming, in a chronic kidney disease, because the GFR is going very low. Then comment on the serum calcium of this patient. So I'm waiting for the answers. This is a patient who is suffering from CKD. Let's see how many of you can tell me the answer. Okay, you've already started giving me the answers. So I can see Divya, Ishan, Rohitash, Dopa, Mishti. Okay, so you people are confused between B, and okay, majority of you are saying B. Some of you are saying even C. Okay, C. This is a patient who is suffering from chronic kidney disease. In a chronic kidney disease patient, what actually happens? In a chronic kidney disease, the problem is that the kidney is secreting vitamin D, which is responsible, for the calcium metabolism inside the body. Now, when the patient is suffering from CKD, there is no vitamin D secretion. And if there is no vitamin D secretion, what's going to happen? In any kind of chronic kidney disease, where the vitamin D is not there, calcium level is low inside the body, what comes up? There is hypersecretion of the parathyroid hormone. We call it as secondary hyperparathyroidism. Now, what this parathyroid hormone eventually is going to cause in the body? Now, because of the CKD, the calcium levels are low. But because of the functioning of the body due to, hypocalcemia, which is happening, parathyroid hormone is coming up, and this parathyroid hormone is going to increase the calcium levels. This kind of calcification in which the calcium levels are increasing, which is occurring due to any kind of vitamin D related disorders, or let's say the parathyroid hormone is working more, we call this kind of calcification as metastatic calcification. What we call it as metastatic calcification. And in the patients of metastatic calcification, yes, you are right. You are right. You people are right. Thank you very much for these answers. So it is a metastatic calcification, and we know that we have two kinds of calcification, guys, right? So we have one kind of calcification is dystrophic, and the second one is metastatic. In the dystrophic calcification, always remember there was a question which came in your exam very recently, in the last exam as well, that where would you find dystrophic calcification? Dystrophic calcification is always occurring at the places where there is some kind of injury, where the cell is getting damaged or the cell is dead. So the serum calcium in these patients is going to be even the serum calcium levels being normal is enough to cause calcification in these people, whereas for metastatic it is going to be high. And for dystrophic calcification, because they are occurring in the tumors, we are also talking about a very important finding, that is your Samoma body. And we know that these Samoma bodies, they are concentric lamellated calcium deposits, which we are seeing at three important locations. This question has been asked repeatedly in your exam once again, and the mnemonic which we have done is PSM. So papillary tumors, serous tumors, and the meningiomas. So here, because they're asking about a chronic kidney issue, so this is what they have asked. The answer has to be B, higher than normal. Eventually, okay guys? Eventually it would be higher than normal because of excess working of the parathyroid hormone. Okay, so yeah, thank you guys, thank you very much. Akash, Jaggi, Aishwarya, Senivasan, Ikra, Trilok, Alia, thank you very much. So you are giving the right answers. I'm really very happy. Now let's see question number 2. Mr. B, a 73-year-old man brought to the casualty in an unconscious state. He was declared dead after initial examination done by the duty doctors. Upon performing the post-mortem, it is noted that the cause of death is blockage of the coronary vessel. That means the patient had an MI. A biopsy was taken from the infarcted area, okay, and on HPE, pigment deposition is seen around the nucleus of the cardiac myocyte. So, as soon as you see two important words here, a pigmented deposition, and it is around the nucleus, okay, all are true regarding the same except. Now, please be very careful in the exam when you are getting these kind of questions, because here, okay, so you have already started giving me answers, and, so, you can see the smile. So thank you very much for giving me the right answers. Yes, we know that what kind of pigment it is getting deposited around the nucleus of the cardiac myocytes. That's going to be your lipofuscin. And this lipofuscin, we know that there are other names of this pigment. They are your aging pigment. It's your wear and tear pigment. It's lipochrome. So we have to find out what statement, guys. We have to find out the false statement, okay? So it is due to aging process. Yes, it is true. Can be stained by pearl stain? No, it can't be. Because what can be stained by a pearl stain? A pearl stain will always and always stain iron. It is not a stain for lipofuscin. What are the stains for the lipofuscin? A very important stain I told you, that's going to be your Sudan 3. Even, for a lipofuscin, you will have Sudan 3, not Pearl's stain. So it is going to be Sudan 3, not Pearl. So this is your false option. This is your false option. Generally due to free radical injury. Yeah. What is the reason for lipofuscin deposition? The reason for lipofuscin deposition will always be a free radical injury or a lipid peroxidation, right? And it is golden brown in color. Definitely, it's a golden brown in color pigment, perinuclear pigment, which we have done multiple times in the classes. So the correct answer for this question will be this, D. This is the correct answer. Yeah, Abhishek, it will be oil red O also. It can be because it is lipofuscin, so it contains lipids. So fat का stain oil red होता है, तो वो भी आंसर हो सकता है उसके अंदर. Thank you. Then question number 3, Mr. C, a 23-year-old patient came to the medicine OPD with complaints of respiratory distress. He has been diagnosed with asthma. Okay. He complains of numbness in the hands and running nose from some time. On further evaluation and testing, the diagnosis of Churg-Strauss syndrome. Okay, Churg-Strauss syndrome is made. What is the interleukin responsible for the biopsy findings related to the disease? So, okay, what is the interleukin responsible? Guys, you have to see the options that we are talking about. Syndrome here, which is the Churg-Strauss syndrome. Now, Churg-Strauss syndrome, we have to remember the findings. Yeah. Very good, guys. Yeah, absolutely. You are right. Thank you very much. I mean, I just cannot read the names also. The answer is coming so fast. So, thumbs up, guys, thumbs up. Churg-Strauss disease or Churg-Strauss syndrome, basically, it is involving the small vessels, and in a Churg-Strauss disease or syndrome, there are vessels which are very small vessels. They are going to be involved, and the vessel pathology in Churg-Strauss syndrome, you can also call it as eosinophilic granulomatosis with angiitis. So, this is the other name of this disease. And when we are using the word eosinophilic, basically the examiner is wanting to know that whether do you understand that, whenever we have an eosinophil, what kind of interleukin is responsible for this kind of C? Yeah, absolutely. Yeah, Rohit, Suraj, Mudala, Abhishek, Shivaji. Yeah, very good, guys. Very good. Thumbs up. The correct answer is going to be your interleukin 5. The answer is C. When we are talking about interleukin 12, we are talking about macrophage activation here. When we are talking about interleukin 1, now this is some interleukin which is very closely associated with pyrexia. Interleukin 5, it is for eosinophil, and TGF-beta, we all know it is for fibrosis. The major interleukin which is working with some other interleukins in the form of when the body needs repair. So the correct answer for this question would be C. Moving on to the next question. Miss D, a 17-year-old girl, came to the surgery OPD with complaints of some growth around the umbilicus. She gives the history of piercing in recent past. On physical examination, the growth is seen around the piercing area as given in the image below. All are false regarding the same except. So, beta, the options, again, when you are getting these kind of questions, you should be very clear that what you need to find out. You need to find out a true statement here. So, when you need to find out a true statement, let's see. First of all, you should understand, what kind of growth it is. So, this is abnormal, right? This is some kind of abnormal growth. This growth which is there, first of all, I want to know that what exactly is this. Yeah, Shahrukh, very good, beta, very good, Shahrukh. It is this growth which we have. This is called as, Alia, you are right, this growth is keloid. Yeah, Misty, it is keloid. Absolutely. So you need to find out the true statement. It is always genetic. No. Keloid can run in the family, but we cannot say that it is always and always genetic. If The option would have been it is genetic. Yeah, it could be genetic. But when I have written here the always word, that means it's a false statement. So it cannot be the answer. When we are talking about the most common site is sternum, yeah, the most common site for any kind of keloid development is sternum. So this is the true statement, and this should be the answer. But let's see the other statements as well. Removal of piercing will regress the growth. Keloids, they never regress themselves. What are the kinds of scars which can regress themselves? They are your hypertrophic scars. So keloid will never regress, and there is high risk of malignancy. No. With keloid, they might look bad. It is looking bad, but there is no risk of malignancy as far as keloid is concerned. So all the three options, A, C, and D, and wrong. And the correct answer is most common site is sternum. This is the true statement. So make sure that you are reading the question properly, that you need to find out the true statement here. Okay? Yeah. Now, question number 5. Miss E, a 4-year-old girl. Again, it's a long question. So, we need to read the last line first. Comment on the pathogenesis of the process. Miss E, a 4-year-old girl child brought to the pediatrician by her parents with complaints of severe abdominal pain. Okay. She has been crying the whole night, holding the abdominal area. Okay, there was an abdominal pain, severe abdominal pain. They also gave a history of her being reluctant to play from past few days as she's complaining of some joint pain while playing. So there are joint involvement as well. On examination, multiple small bleeding spots are seen over the lower limbs, but the platelet count was absolutely normal. So there was bleeding, but there was no thrombocytopenia. Even the examiner has given you the diagnosis as well, that diagnosis was Hinoch-Schaulen purpura was made. Comment on the pathogenesis of the process. So as I can see, thank you very much, guys. Thank you very much. As I can see that you can understand that Hinoch-Schaulen purpura is a type 3 hypersensitivity reaction, and when we are talking about a type 3 hypersensitivity reaction, it's gonna be immune complex mediated. So it is not anaplasia. What is anaplasia? It is your abnormal growth, undifferentiated growth. So it is not anaplasia. Viral infection can cause it, but more commonly the Hinoch-Schaulen purpura is autoimmune disease. So it's an immune complex mediated injury. Okay, so you need to find out the most probable answer here, and it is immune complex mediated injury. There are two mnemonics which we have for the hypersensitivity reaction. Recently in your exam, from past, I think 3-4 times they were not asking about the hypersensitivity examples, but in last exam they asked about the hypersensitivity example. So we have a knack that they might repeat the questions, the topics, rather not the question. So there can be a question coming out from it. Make sure that you're learning it properly. When we are talking about a type 3 hypersensitivity reaction, make sure that you know the mnemonic. The mnemonic is SHARP, very widely used, very common mnemonic which we have learned. S stands for SLE and serum sickness, Hinoch-Schaulen, Arthurs, your reactive arthritis, and PSGN. And we have learned many a times that whenever somebody is talking about a glomerulonephritis, whatever the kind of glomerulonephritis it is most commonly, not always, but most commonly, it is type 3 hypersensitivity reaction. Yeah, guys. Yeah, thank you. Thank you very much. Thank you very much. Yeah. So it is type 3 hypersensitivity reaction. The type 3. Now, question number 6, Mr. F, a known diabetic who was suffering from chronic kidney disease, was on hemodialysis from past 2 years. With his deteriorating renal health, doctors planned a renal transplant. He underwent a successful renal transplant and shifted to the post-op. After 3 days post-transplant, he started showing features consistent with transplant rejection. Okay, what is the probable cause for this reaction? So we are talking about yeah, Jack Sparrow, totally right. It is your cola-colored urine in PSGN. Cola-colored. Yeah. The parents complain of child drinking a lot of cola. But actually, he is not drinking a lot of cola. It is hematuria. Okay. So what is the answer for this question? Okay. Wow. Amazing. Each one of you. I want to clap for you people. Thank you very much for, giving such great answers. So obviously we are talking about 3 days after the the operation. So 3 days, when it is already, in some days to less than 6 months, it is acute graft rejection. And when we are talking about an acute graft rejection, it is more commonly type 2 hypersensitivity, right? So it would have been, let's say 3 months, 4 months, 5 months, then the situation would have been little different, because see, for the hyper sensitivity reaction leading to the graft rejection, whenever we are talking about a graft rejection, there are 3 kinds of graft rejection: hyperacute, acute, and chronic, right? Now, when we are talking about a hyperacute graft rejection, it is generally happen within hours, with minutes to hours after the operation, after the transplant. So it is minutes to hours, right? And when we are talking about an acute graft rejection, it is from days to months generally. And when we are talking about a chronic graft rejection, it is more than 6 months. After 6 months of the surgery, the rejection would be there. Now, you need to understand that, because they are saying 3 days, so because it has used 3 days, I have told you multiple times in the classes that this is type 2 hypersensitivity. This is type 2 more than type 4. And when we are talking about a chronic, it is type 4 hypersensitivity reaction, because it is going to be a T cell mediated injury. So, we are talking about the hypersensitivity here. Now, this acute graft rejection is of 2 types actually. When the type 2 hypersensitivity is causing the acute graft rejection, you call it as acute humoral rejection. Humoral means, beta, B cells are involved in the graft rejection. So it is generally towards the initial phase of acute rejection. And the second one is when type 4 hypersensitivity is causing an acute rejection, you call it as acute cellular rejection, because T cells are making a part in the graft rejection. So graft rejection, if they ask you which cells are causing it, T cells are causing the graft rejection. But but for the graft rejection, what is important? Your T cells and your antibodies, because they have used the 3 days. Initial part mein baat kar rahe beta. So that is why your answer would be here. This would be the answer, type 2 hypersensitivity, and that's gonna be antibody mediated. IgE cannot be, because IgE is type 1 hypersensitivity. We are not having any graft rejection which is due to type 1 hypersensitivity. IgA, no, it is not anyway related to the graft rejection. And T lymphocyte mediated, it could have been, but then the time period is, early, abhi hua hai. So that is why. Okay. Kunj Talod wala. Sir, mere sahi ho rahe hain questions. Very good, man. High five. If the questions are right, high five. Now, question number 7. Which of the following is not true? Now, let's see how many of you get it right. First, calcitonin is the marker for medullary cancer thyroid. Is it a true? You have to find out the false statement, guys. You need to find out which statement. False statement you need to find out. So let's see how many of you get it right. I'm waiting for the answers. Yeah. So calcitonin is the marker for medullary carcinoma thyroid. Is it a true statement or a false statement? So calcitonin, yeah, calcitonin is a marker for medullary. Okay, you've started giving the questions right away. Very good. Very good, Sultan. Very good. Yeah. So see, calcitonin is the marker for medullary carcinoma thyroid. We are sure about it. So any option which is containing first as the option, that has to be wrong. So we can rule out straight away A and B, because A and B contains 1. अब अपना काम क्या रह गया? We have to find out कि भाई बाकी में से क्या सही है. Let's see. CA 19.9 is the marker for ovarian cancer. No. Ovarian cancer, the marker for ovarian cancer has to be CA 125, right? So 2 is definitely wrong. And once we know that 2 is wrong, so whether we are very sure about this or not, we don't have to think about. This is something which I'm telling you when you're not able to solve the question in the exam. If you know this, कि यार ये तो पक्का गलत है ही, ये तो सही नहीं हो सकता, तो ये कहाँ पे है? C में. तो correct answer क्या हो जाएगा? C. That's it. So now let's see. EGFR1 is seen in non-small cell carcinoma lung. Yeah. Definitely. Non-small cell carcinoma का मतलब क्या हो गया बेटा? What is non-small cell carcinomas? Non-small cell carcinomas are squamous cell carcinoma and adenocarcinoma. and we have done in the classes. Do you remember that table we have done? And you must be knowing that adenocarcinoma, when I'm talking about adenocarcinoma lung, I've told you EGFR1 for that. So this is a true statement. So, you know, number 1 is true, number 3 is true. So bacha kya yaar? RAS is the tumor suppressor gene? No. RAS is not a tumor suppressor gene. RAS actually is what? It is an oncogene. So the correct answer for this question is going to be C. 2 and 4, they are not true. 3 and 4 cannot be the answer. Yeah, 4 is not true, but then the 3 is entirely true. So this cannot be the answer. So again, the correct answer is C. And I really am really proud of you that the way you people are answering. Thank you very much. I mean, it gives a wide smile on my face. Thank you. Question number 8. Mr. G, 44-year-old, came to the ENT OPD with complaints of hearing loss and ringing sensation in both the ears. A soft tissue mass is noted and on-HP following finding is seen. So this is what you are seeing on the histopathological examination. Choose the correct statement regarding the same. So you need to find out the correct statement. Okay, now let's see. Let's see how many of you are giving the answer. Okay. So we are talking about this, okay? You need to find out the correct statement regarding this. The first option is, this is an acute inflammatory infiltrate with presence of Samoma body. Do you see any Samoma body? Samoma body, they are concentric laminated deposits. So we are not seeing any Samoma body here. So, I mean, this has to be a wrong statement straight away. So once this is wrong, already we can rule out that, you know, D cannot be the answer. Now we are left between B and C. So let's see. Yeah. Okay. So here the situation is that you need to find out. Many of you are giving me an answer which is C. Beta, no Pushpa, no. Anybody who is seeing, no. Beta, this is a question of schwannoma, which is also called as acoustic neuroma. This is a tumor of cranial nerve 8th. That means whenever somebody would have a tumor which is related to a cranial nerve 8th, we know it is supplying the ears. So obviously there would be problems in the ear. That is why sensory neural hearing loss will be there, ringing sensation, tinnitus will be there inside the ear, and you are seeing schwannoma. Okay, you are seeing acoustic neuroma. Now in this, when you take a biopsy, what you see 3 areas here. What are those here areas? See, we have, let me zoom it for you and let me tell you, these are the areas which are highly cellular areas. Okay, now these highly cellular areas, what they are called as? These highly cellular areas, they are called as antennae A. Okay, then we have some hypocellular areas where you can see why am I saying these are hypercellular? Because I'm seeing so many nucleuses, right? So on a pathology slide, you all say it's pink and blue. So you are seeing blue color. What is blue? Blue is nucleus. So you're seeing so many nucleuses here. So this is, hypercellular area. This is antennae A. Then you are seeing this particular area, which is comprising of cells, but not too much. So we call this area as antennae B. And then you can see this particular area here, yeah. What is this? This is an area which is, having no cells whatsoever. So whenever we are talking about an area which is, more or less acellular, we call this area as Verrucke body. क्या बोलते हैं बेटा इसको? Verrucke bodies. So now you see, antennae A is hypercellular, antennae B is hypocellular, and Verrucke bodies, they are acellular. Okay, now let's read the question. So we are having, अरे धवल कोई टेंशन मत ले यार, simple mistake. अभी अपने पास time है धवल. We still have time. We still have time. That's why I said that it is not important that you are finishing the paper quickly. It is not important that how fast you are giving the answer. Important क्या है बेटा, एक mark count करेगा ना exam में. Every mark in the exam is going to count, है ना? And if you are just putting 5 seconds more in a question, if you're reading the question properly, you know that as soon as you see this figure, as soon as you see that, okay, they are talking about hearing loss, and you see this figure, you understood, okay, they are talking about schwannoma. And as soon as you talked about schwannoma, you are like, okay, yeah, this is right. And then you read this and you got this area. Antony A, schwannoma mein Antony area hota hai. And many of you have answered C also in this. But you didn't read that what is written here. This is acellular areas. Do acellular areas called as Antony A? No. They are called as Verrucae. Antony A is hypercellular. Antony B is hypocellular, guys. So make sure that you are not making these silly mistakes in the exam. How can we avoid it? By doing a very simple thing. That is putting 5 seconds more to a question. Reading the question properly. That's the key. It will be a big key in your exam on 4th. Read the questions properly. They would not be at all these questions. Whatever questions we have done, you see, all these questions are long. So if you're losing hope by seeing long questions, you should not. Questions would be long. That's not a problem. But what they are telling you, if you have a long question, guys, that means they're giving you more information. You're getting more information. You have more chances of making the answer right. So don't worry about those questions. Okay, just put 5 seconds more. This is wrong. This statement is entirely wrong. What is the correct? You need to find out the correct statement. The answer is B, guys. Okay. Now, moving on to the 9th question. True regarding the given karyotype. You need to find out the true statement regarding the given karyotype. Okay. So I'll just show you the karyotype. This is the karyotype. We see first chromosome, second, third, fourth, fifth. Everything looks normal here, right? The biggest chromosome, if somebody asks you what is the biggest chromosome, tell me quickly what is the biggest chromosome we have. Can you please tell me what is the biggest chromosome? Nuja, कुछ नहीं भूल रहा है. यहाँ पे लग रहा है कि आप भूल रहे हो, but actually you are not. Actually you are not. Beta, this is the strongest thing you have in your body. Okay, just rely on that. You people have done a really very, tremendous work in last 3.5 months. Don't think like that. It's playing with you. Okay. Yeah. Very good, guys. Very good. We have chromosome number 1, which is the largest chromosome. What is the smallest chromosome? If somebody is asking you the smallest chromosome, it is always going to be 21. This is the smallest chromosome we have. So let's see. 1, 2, 3, 4, 5. It is correct. 6, 7, 8, 9, 10. We are not seeing any abnormality whatsoever. 13, 14, 15, 16, 17. Oh, everything is fine. So here also it is fine. Here it is also fine. Okay. So we are having 2x. Y should not be there. But this has Y. That means what becomes the karyotype of this? The karyotype, if I have to write a karyotype here, what will I write? I will write 47XXY because I'm getting 1 chromosome extra here. So this is a patient of, for what is 47XXY? 47XXY. Yeah. What is 47XXY, guys? Klinefelter's. Yeah, Prince, you are right. Manish, you are right. Very good. Now let's see that, when we are talking about a Klinefelter syndrome, let's see the true statement. Microcephaly with polydactyly. No. If we have a microcephaly and polydactyly, generally these are features of trisomy 13. That's your Patau syndrome. Cleft lip and palate with prominent occiput. Okay, occipital region coming out. This is your Edward syndrome. So E for Edward and E for 18. This is your trisomy 18. So this cannot be a true statement here. Tall stature with poor beard growth. And D option is short stature with shield chest. So when we are talking about a short stature with shield chest, we are talking about Turner syndrome. What is Turner's? 45XO. And this cannot be the answer. So I mean A, B and D, they are ruled out. What we are left with? We are left with C. There has been no exam in last 2 years, medical exam I'm talking about, which, yeah, absolutely, guys, absolutely. God bless you all. God bless you. So this is, which does not contain a question from Klinefelter's or Turner syndrome. So make sure that when you are going for the exam, read them properly, okay? Read them carefully because we expect a question. Now, a boy, this question I want you people to answer, okay? I'm waiting for the answer. So, a boy who is a carrier for autosomal recessive disorder marries a girl who is genotypically absolutely normal. True regarding the same is A. None of the child would be affected, all would be carriers. 50% carriers, 50% normal. Okay. Then 25% affected, 50% carriers, and 50% affected and 50% carriers. Okay, let me see what are you answering? Okay. Okay. Uh-huh. So there are B and C. This is what you are confused in, B and C. Let's see. But they are talking about an autosomal recessive disorder, which is a carrier, okay? So, we have this situation. He's a carrier, right? You must be knowing that autosomal recessive disorders, they can only manifest themselves when they're homozygous, when both the alleles, they are mutated. But if we are saying it's a carrier, that means we are talking about that only one allele is mutated and the second allele is normal. That is why this person is carrying the disease, but it is not showing it. And then we are marrying it to a normal lady. Okay. So what is the probability? The first probability is this, second is this, third is this, and fourth is this. So these are the four probabilities which we have. Now tell me, what are these? Do they have mutation? No. So what is this? Normal. And do they have the mutation? Yeah, they have it. But whether they would show it? No. It's a weak mutation which is there. So a weaker mutation is there, but who is strong? The normal allele. And whoever is strong, that allele is going to show itself. So will they show the disease? No. But do they contain the disease? Yeah, they do. So what they're called as? They're called as carriers. So what is the probability we are getting? 50% normal and 50% carriers. So what is the correct answer? The correct answer is B. So to all those who have answered B, thumbs up. To all those who have answered C here, again I'm saying, just wait a second before you answering. Okay? I am sure that you people knew it, but then because you want to answer quickly, that's why the problem. So chalo, aage chalte hain. This is something which you should always follow. I mean, Hindi mein likha hai, there might be some people, yeah, Nikhil, it's B. There might be some people who might not understand this, so I'll say this in English also. सफल होने के 3 नियम: खुद से वादा, मेहनत ज़्यादा, and मजबूत इरादा. So this is what we want from you people. That you should promise yourself that the next 23, 24 days which you have for the exam, from now on, you promise yourself that you're going to work very hard, the hardest you can, and have a strong will. Okay, make a promise that I'm going to do whatever it takes to get it through. Work the hardest you can, guys. Hardest. You people are working very hard. But I want you to work 200% of your capacities at this point of time. Because whatever is going to happen on 4th, when the result is going to come, things are going to change. I want a smile on your face when you see the result. I want that happy tears in your eyes. When you see that result, it's written PASS over there. All these 4-5 months of this hardship, they're going to run through your mind, You will remember every second spent. But work 200% for that. And have a strong will. Nothing should take you away from your target of clearing this exam on 4th. Nothing. Nothing means nothing, guys. Nothing is more important than your own future. Okay? Now, question number 11. Mr. H came to the OPD with complaints of fatigue, weakness, and tingling sensations in the hand. He completely went vegan 10 months back. He is on a weight loss spree and on a very strict diet comprised of only egg whites and soya chunks. On CBC, hemoglobin is 9 gram per deciliter. MCV is 136 femtoliters. Okay. So we know that, okay, by just seeing the hemoglobin levels, we can understand it's a patient of anemia. MCV is high. Okay, thank you already. Wow. So MCV is high. That means the RBCs are big. What is the most likely cause for anemia in this patient? Now, the most likely cause for anemia in a patient, they are talking about a macrocytic anemia. And when we are talking about a macrocytic anemia, what is the mnemonic we have learned? MDH. So, what is M here? Megaloblastic anemia. And when we are talking about a megaloblastic anemia, what are the vitamins which are vitamin B12 and vitamin B9? So this is a patient who is suffering from vitamin B12 deficiency. That's it. So you need to find out the most likely cause. Vitamin B3, no, not related. Iron, no. In iron deficiency, it's a microcytic anemia. Iron deficiency anemia, it's a microcytic anemia. So the MCV would be lower, not higher. Vitamin B12, yeah. This is the answer. CD55 deficiency, what it's going to cause? Do you remember CD55, 59, guys? This is the protector of the RBC, PNH. This is going to be causing PNH for us. So again, this cannot be the answer. The correct answer for this question is C, vitamin B12. Okay. Then question number 12. Now in question number 12, read the question properly. Comment on the pathogenesis behind the given condition. Okay, you need to find out the pathogenesis behind it. Let's see the question. Parents came with their 9-month-old baby to the pediatrician with complaints of baby being very lethargic and feeding difficulties. Okay, baby seems to be pallor and very weak. So anemia ho raha hai isko. HB is 6.8 gram per deciliter. Now with near normal TLC and platelet count were okay. Near normal TLC and near normal platelet counts were noted. On HB electrophoresis, HbA was reduced. So they are saying HbA low and markedly high HbF. Okay. Comment on the pathogenesis. First you tell me guys, what is the disease? Dr. Dream, once live it twice. Yeah, you are right. This is absolutely correct. This is the patient who is suffering from, I'll give you 5 more seconds. I just want, yeah, Shanawaz. Very good. Nice guys. So this is a patient who is suffering from thalassemia, guys. This is a thalassemia patient. And that to which thalassemia? See the hemoglobin levels, it's so down. And this thalassemia is presenting itself quite early in life. What is the type of thalassemia which presents very early in life? It's a beta thalassemia. Which kind of beta thalassemia? Because it is presenting early. It's severe. So it is beta thalassemia major. And I told you, what is the hemoglobin electrophoresis for a beta thalassemia major? In the beta thalassemia major, the HbF would be high. We discussed this. You all must be knowing that normally in the adults, hemoglobin A, we have 3 hemoglobins, hemoglobin A, A2 and F. Now, we always say that in the adults, which hemoglobin is more, guys? In the adults, we have hemoglobin A more, 90 to 95%. And A2 is like, less than 3.5% inside the body, and F is going to be very low. So we have low F in the adults, around 1 to 1.5%. In a child, when we are talking about a child, obviously HbA is low and HbF is more. But then what is the age group of this child? The child, when I say it's less than 6 months. After 6 months, the hemoglobin concentration changes. And if you find out the hemoglobin concentration in a child, it would be hemoglobin A more than F. But here you are getting on HB electrophoresis hemoglobin F more. And in the beta thalassemia, I told you, because the beta chains are going to go very low because it's major. So what are the chains which are going to come up? The delta chains and the gamma chains, because it is your major. So kaun si chains aayenge beta? In the major, it will be gamma more. So now you will get a hemoglobin which is alpha 2 gamma 2. And if you have alpha 2 gamma 2, what is alpha 2 gamma 2? HbF. So HbF is a finding for beta thalassemia major. As you people, yes, you are giving the correct answer. Thank you very much for that. This is nonsense point mutation. This is the question which is there from genetics. It is nonsense point mutation. 13. Mr. I came to the medicine OPD with complaints of fever, severe fatigue, breathlessness, and joint pain. Okay. On CBC, the hemoglobin is 8 gram per deciliter. This is a patient who is anemic. MCV is 66 femtoliters. That means we are having a microcytic RBC, because what is the normal MCV? The normal MCV is 80 to 100 femtoliters, right? So microcytic RBCs are there. MCH also is going low. What is normal MCH? 27 to 32 picograms. So it is MCH also is low. PCV is also low. Packed cell volume. It is approximately 3 times the hemoglobin. So hemoglobin is 8 gram per deciliter. So obviously PCV is also low. And RBC count is 3.1 million per cubic millimeters. So what is the normal RBC count? It is from 4 to 5.5. So RBC count is also low. So you have everything low, HB low, MCH low, MCV also is low, and the RBC, total RBCs are also low. So, wow. Wow, guys. Wow. Amazing. Amazing. Shivaji, Kishore, Rameshwar, Shweta, Virendra, Nakibur, Rajul. Nice, man. Nice. I'm seriously, you people, I don't know, how you take it and how do you feel about it, but we as faculties, when we see all this, it gives us such confidence and such happiness, and we really want to congratulate you, and we really want you to sit and think for a minute. Where were you 4 months back? 4 months. This question 4 months back would have been a problem, but right now, see for yourself. Wow. Amazing, guys. Congratulate yourself. Take a moment and tell yourself that I am on the right path. I have to just be on it for the next 25 days more. Not 100%, 200%. Okay. This is pernicious anemia. No, it can't be. Pernicious anemia is an autoimmune condition. So it can't be. There is no autoimmunity we are talking about here. Aplastic anemia. When they're saying aplastic anemia, there is no hematopoiesis. So patient goes in pancytopenia, and there the RBC count will be more, even still lower. So aplastic anemia we cannot talk about here, because you need to have pancytopenia. Thalassemia and iron deficiency, because I'm saying microcytic anemia here. So microcytic anemia के लिए अपन ने mnemonic पढ़ा था बेटा शीतल, right? What is S? Sideroblastic. I is iron deficiency. T is your thalassemia minor. A is anemia of chronic disease, and L is lead poison, right? So, it is not sideroblastic anemia, because the iron content has to be more in these people. It can be iron deficiency anemia, definitely. It can be thalassemia also, because we are not getting anything to differentiate them as such. Anemia of chronic disease, there is no history given for any chronic disease. So we cannot, totally say that it can be an anemia of chronic disease, and that is also not given in the option. So there is no point of thinking about it. So in this, we should be differentiating between I and T, because these two are given in the options. Now, whenever you have this kind of a problem, when you want to differentiate between iron deficiency anemia and thalassemia, I know, okay, so I know that you people must be knowing that what is the index we are doing here. The index we are doing is Menzer index. Now, in the Menzer index, what is Menzer index? It is your MCV upon RBC count. Now, when we are talking about MCV upon RBC count, you know that whenever you have this problem, you need not to calculate. If the Menzer index is high, this is IDA. And if the Menzer index is low, it is your thalassemia. Okay, high is IDA, low is thalassemia. Now, please try to understand that in iron deficiency anemia, the problem is, the thalassemia which we are talking about here, this thalassemia which is there in the microcytic anemia, this thalassemia is generally a thalassemia which is a thalassemia trait, or maybe a thalassemia minor. So when we are talking about this kind of thalassemia, it's more about that the RBC count will not be so low in these patients. But here the RBC count is very low. So when you have something denominator which is very low, So the overall value will be high in these patients. So whenever you see, I'm just telling you how to solve these questions in the exam. If you see low RBC count, low MCV, then probably this question would go towards the iron deficiency anemia. If you are seeing more or less normal RBC count plus the MCV is going low, then that means your RBC count is normal and your MCV is low. So the overall value will be low, because what is getting low here? The numerator. So the overall value will be low. What is the value? If let's say they ask you a value also. So if it is more than 13, it is iron deficiency anemia. And if it is less than 13, it is your thalassemia. Okay. So this is what you should be knowing about here. This is a question which is there on the Menzer index. And yeah, Prince. Yes, Sundaram. Positive vibes, definitely. Suresh, yeah. So the correct answer for this question is D. Moving on to the next question. CBC of a patient shows RBC 3.1 million per cubic millimeter, WBC 1100, platelet count 68,000. So everything is going low. That means this patient is a patient who is suffering from pancytopenia. Okay. Let's move further. On bone marrow biopsy, fat cells, okay, with very few cellular content seen. Very less. Marrow should contain normal cells, marrow should contain all the primitive cells inside, because marrow is what is sitting in the marrow. In the marrow we have hematopoietic stem cell sitting. So if the hematopoietic stem cell is sitting, it should multiply into multiple other cells. So, but that is not seen. All the marrow is, shifted, or marrow is transformed into fat. Spleen and liver were unremarkable on general examination. That means there is no hepatosplenomegaly in these patients. And wow, yeah. Severe vitamin B12 deficiency could be, but then why there would be, pancytopenia in these patients? Pancytopenia can be there in megaloblastic anemia, but then very rarely we see that, number one. And secondly, we need, if that is there, hepatosplenomegaly might be seen. So that is not there, so it cannot be severe vitamin B12 deficiency. All the bone marrow, in the vitamin B12 deficiency, when you go into the bone marrow, you are seeing hypercellular bone marrow. I mean, it is not hypercellular, but because the cells which are there in the bone marrow, they are big in size. What we call them as? We call them as megaloblasts. Do you remember? Megaloblasts, they are big cells, okay? Sieve-like chromatin. So they are filling the entire marrow. That is why we are thinking that there's so many cells inside the bone marrow. So it will not be, changed with fat. So here on the bone marrow, fat cells are seen. So it cannot be severe vitamin B12. Aplastic anemia? Yeah. It can be, because pancytopenia is there, bone marrow is completely gone, so aplastic anemia could be there. Anemia of chronic disease? No. In anemia of chronic disease, again, nothing of this sort happens. And pancytopenia, no, it's generally not seen that too often. PNH could be there, because PNH gives us pancytopenia, but in PNH, as I've told you multiple times, you'll see hepatosplenomegaly. You will not be seeing normal, spleen and liver. So these two cannot be the answers here. It will be aplastic anemia. Yeah. Then question number 15. Mr. J, 58-year-old male presented with weakness. But these kind of questions, whenever you get this kind of a question, do not worry. Okay? Just don't worry. Long question with an image, मतलब ज़्यादा चीजें दिए अंदर solve करने के लिए. देखते हैं आप. Mr. J, 58-year-old, presented with weakness, pallor, fatigue, and multiple purpuras. On complete blood count, hemoglobin 9.1 कम हो रहा है. TLC 56,000. What is the normal TLC? 4 to 11,000. So TLC is going high. Okay. In the DLC, what are you seeing? 55% neutrophils, 4% lymphocytes, monocytes, basophils 11%. Oh my God. So this is something which is, again a finding. This is again a finding. Whenever you have more basophil, what is the normal basophil content? The normal basophil inside the body, it is 0 to 1%. But here you are getting 11% basophils. That means it's basophilia. Okay. And do you remember when we think about basophilia, what it could be? Let's see. Metamyelocytes, 10%. Where? In the blood. In the blood, you are seeing cells from the marrow. So metamyelocytes, myelocytes, promyelocytes, and blasts, only 2%. So, whenever we are seeing so high TLC, the first thing that comes into our mind, that's leukemia. Now in leukemia, we can have two kinds of leukemia, the myeloid and the lymphoid leukemia, and the acute and chronic. Now when you have to differentiate between an acute, because if you see the options, now in these options, they're talking about acute myeloid, acute lymphoid. But now you see that here, let's talk about this. First, acute and chronic के लिए क्या decide करोगे बेटा? Blast percentage. So blast is how much? Only 2% blast. So it cannot be acute. तो सबसे पहले तो बेटा acute काट दो. Because for acute leukemias, how much blast percentage do you need? More than 20. So काट दो. Acute खत्म हो गया. अब अपन क्या बचते हैं? Either it can be chronic lymphoid or chronic myeloid. ठीक है. अब अपन देखते हैं what are the cells they have given. So if you see the cells, the blast which you are getting in this, they are big blasts. You see. Now, यहाँ पे क्या दिख रहा है बेटा? You are seeing blasts which are big, but you are seeing so many inflammatory cells also. And you are seeing which cells more? Basophils. Eosinophils also could be more in this. Two things I told you, basophilia and eosinophilia. And whenever you are solving the questions of acute and a chronic leukemia, just make sure that, see the blast percentage. The blast percentage is very important. If it is more than 20% blast they have given, it's going to be acute. If they are writing less than 20% blast, it's going to be chronic 100%. Okay? If let's say you are still getting confused, these cells, these metamyelocytes, these myelocytes, promyelocytes, they are your normal cells which are there in your bone marrow when the hematopoietic stem cell is making a normal WBC. So basically your cells which should be in the bone marrow, they are coming in the blood. So when the normal cells, they come out in the blood, normal cells, this is called as shift to left. What it is called as? Shift to left. So whenever you are seeing a shift to left, and these cells which should not be there inside the blood, but you are seeing them with a blast percentage which is less than 20, it has to be chronic. Okay? Now, this is a patient of chronic myeloid leukemia because you are getting so much of basophils. If it would have been chronic lymphoid leukemia mein beta, these lymphocytes would have been more. In this, the lymphocytes are going low, only 4%. What is a normal lymphocyte? 20 to 40%. You are not even getting normal lymphocytes also. 4%, less lymphocyte. That means it's not lymphoid leukemia. It's a myeloid leukemia because your myeloid cell, we have discussed multiple times in the classes, HSC, myeloid progenitor cell and a lymphoid progenitor cell. Myeloid progenitor cell is making 4 cells. WBCs की बात करें. Only WBCs I am talking about. 4 types of WBC and lymphoid is one type of WBC. So what is one type of WBC which a lymphoid is making? Lymphocyte. And the 4 types here, neutrophil, eosinophil, basophils and monocytes. This all is coming from a myeloid cell. और आप देखो, you are seeing basophil more. So you are seeing this cell more, मतलब ये leukemia कहाँ से आया है? Myeloid regions. So what is the correct answer? Many of you have already given me the answer. Thank you very much. This is your CML. 922. 16th. Mr. H, a 43-year-old man, presents with fatigue, weakness, with bleeding gums since past few weeks. Bleeding gums. Okay. They are asking about the diagnosis. Clinical examination reveals pallor, superficial skin bleeds, hepatosplenomegaly, and lymphadenopathy. Oh. On CBC, hemoglobin is 11 gram per deciliter. WBC count is 2.6 lakhs. Okay. What is the normal WBC count? 4 to 11,000. Platelet 89,000. That means platelets are going low. Bone marrow biopsy shows extremely hypercellular marrow, which is filled mainly with blasts. Okay? Hypercellular marrow, which is mainly filled with blasts. Blasts are peroxidase negative and NSE positive. The most likely diagnosis is, number 1, we are talking about, blast percentage, mainly blasts are there. That means it has to be a acute leukemia. Then all the options, if you see, they are acute myeloid leukemia, they are given. So you need not to tell whether this is acute lymphoid or myeloid. So we are talking about only myeloid here. Now in the myeloid, how do you find out that which kind of myeloid leukemia it is? Now I have told you, thank you very much for the answer. I have told you already that the myeloid leukemia which is there with gum bleeds, gum hyperplasia, it is either M4 or it is either M5. So what is the correct answer for this question? C. M2, this is the most common type of myeloid leukemia. M0, this is the poorest prognosis myeloid leukemia. And when we are talking about M7, this is a myeloid leukemia which is associated with Down syndrome. Okay, so the correct answer is C. Mr. I, 54-year-old man, presents to the OPD with fatigue, tiredness, and cervical lymphadenopathy. On peripheral blood smear and complete blood count, TLC and DLC were absolutely normal. No immature cells were seen in the blood. So, beta dekho, TLC, DLC were absolutely normal. No problem in that. No immature cells were seen in the blood. A lymph node biopsy was performed, which shows diffuse effacement of the lymph node architecture. Okay. Tumor cells with indented nucleus, CD10 positive, BCL2 positive. What is the most likely diagnosis? BCL2. Dekho beta, first thing is what the patient is suffering from. The patient, we are talking about a lymph node being effaced. And we are talking about a cervical lymphadenopathy. That is, lymph node involvement is there. TLC, DLC absolutely normal. That means nothing to do with the blood. And entire lymph node is changed. And there are tumor cells which are having indented nucleus. Inko kya bolte beta? These cells are called as centrocytes. What is the and when we are yes beta, no, people who are saying beta BCL2 positivity, when we are talking about BCL2 positivity, guys, BCL2 is more commonly associated with follicular lymphoma, not with DLBCL. In DLBCL it can be positive, but DLBCL के लिए बेटा ज़्यादा क्या होता है? DLBCL के लिए it is BCL6. So anybody who is giving me the answer C, yeah, the correct answer is A. Very good. Correct answer is A for this question. So follicular lymphoma, beta pehle bhi is na 2. How many letters in follicular lymphoma? 2, you know, F and L. So BCL2 positivity. Don't get me wrong. I mean, you can have BCL6 positivity also in follicular lymphoma, but if you have to choose between 2 and 6, always go with 2. Okay. It can't be Burkitt's lymphoma. No, it can't be. CML? Why not CML? Because we have written, okay, TLC and DLC is absolutely normal. In a leukemia, obviously TLC should be high. So the correct answer is A, follicular lymphoma. Question number 18, a Mr. J, 51-year-old male, complains of long-standing history of fatigue, weakness, fever and malaise. Long-standing history of fatigue, weakness, fever and malaise. If we read the last line, which of the following will be most useful in confirming the diagnosis? They are talking about the techniques. Okay, let's talk about what they are saying. Blood investigation reveals hemoglobin 7.9 grams per deciliter. It's low. TLC 1.5 lakhs. My God. So TLC is high. PBS shows shift to left. Shift to left with numerous myelocytes, metamyelocytes, band formed with numerous eosinophils and basophils. Again, yes. You're right. You are right. We're already talking about, you have started giving me the answer. I mean, guys, these are hematology questions, okay? And these are just not something which I'm just doing it. These are the questions. Likewise, the questions have been asked in the exam. So I've made them a little more tougher for you. But still, Tushar, we'll do it. Not here. Definitely, I'll come up with this. You've asked, so we'll do it. Here you can see all these, basophils are high, eosinophils are high, myelocytes, metamyelocytes, shift to left. So what is this? The diagnosis is CML. And when we are talking about a chronic myeloid leukemia, what is the translocation we are looking at? Translocation 922. What is this translocation 922 called as? Philadelphia chromosome. And whenever we are talking about any kind of translocation, genetic abnormality, what is the most sensitive and specific technique to find out any kind of genetic abnormality? That's going to be our fluorescence in situ hybridization. So the correct answer for this question is FISH. Osmotic fragility test? No, you cannot do. Lab score? No, it can be done when we are trying to find out whether the cells which you are getting, they're mature or immature. Immunophenotyping? You can do the CD markers, but that they are asking most useful in confirmation. So confirming, FISH. Okay, so nice. Master K, a 5-year-old child came to the OPD with some mandibular swelling which is growing at a very fast rate. History of fever with recurrent infections is being given by the parents. On further examination, a diagnosis of Burkitt lymphoma is made. All are true, about the same except. So guys, you need to find out the false statement. Now, when you are talking about the false statement, let's see the false statement. Now, in the false statement, most common translocation is translocation 18 for Burkitt's lymphoma. Yeah, this is absolutely right. Let me, yeah, very good, guys. You've started giving the answers. Burkitt lymphoma, all are true except most common translocation is translocation 18. Yeah, with Burkitt's lymphoma, we have learned how many translocations? We have learned 3. What did I tell you? Burkitt's B, so all the translocation will be starting with the same looking numerical, that is your 8. It's an even letter, so all the translocation will be even, like 814, 82 and 822. The most common translocation will be 814. So this is the right statement, so this cannot be the answer. Generally regresses with time? No, man. Burkitt's lymphoma is a very aggressive lymphoma. This has got very poor prognosis. It never regresses with time. It goes on and on. FMGE gene is mutation. Yeah. The gene responsible, the oncogene responsible for Burkitt's lymphoma is c-MYC. And on HPE, starry sky appearance, yeah. Starry sky appearance in lymphomas, the non-Hodgkin's lymphoma is Burkitt's. And starry sky appearance in immunofluorescence, when we are talking about any kind of glomerulonephritis, you must be knowing it is your PSGN. Okay, so you have the correct answer. You need to find out the false statement. The false statement is B. This is the false statement. Okay, chaliye. Question number 20. Miss L, 21-year-old female, came to the ER with complaints of blood and urine. So hematuria ho raha hai. Again, comment on the finding. So you need to find out the finding. If you see this and you read, you might get to the answer, but still we'll read the question. Never jump to the answers. Just read the question, for God's sake. Okay, you have started giving the answers. Okay, so on urine examination, hematuria and proteinuria are noted. Upon taking the history, she also complains of joint pain, which is migratory in nature. She also had an episode of severe throat infection with mild pyrexia in recent weeks. Okay, so fever history is also there. On performing echo, mitral regurgitation is also noted. Wow. Upon taking the biopsy, the following finding is seen. But what is the diagnosis of this? But you are giving me the right answer. Thank you very much. Yeah, Prince, amazing beta. Yeah, it is rheumatic fever. Absolutely. Yeah. So it is rheumatic fever, and in rheumatic fever we know that group A beta hemolytic streptococci, that's the cause of infection. So throat infection would be there, and little bit of fever can come, and then molecular mimicry happens, and those molecular mimicry, those antibodies can go and damage different organs of the body, mainly the heart, the kidney, and the joints. So this is the finding which we are taking from the heart. This is a patient of rheumatic carditis, which involving the myocardium, and in the myocardium we have this ash of body. This is not coagulative necrosis. The correct answer is C, the ash of body, most characteristic finding. And a cell which I want you to remember with ash of body will be a cell which is your anti-show cell, and it's so cell which is having a caterpillar like chromatin. And if they ask you what kind of necrosis you will see here, it's fibrinoid necrosis. Okay, so correct answer is C. 21st question. Mr. M, 45-year-old man, presents to the medicine OPD with complaints of hematuria, hemoptysis, gum bleeds, and mild chest pain. So see, hematuria is happening, kidney involvement is there, hemoptysis is happening, that means respiratory involvement is there, gum bleeds, and mild chest pain. Okay. X-ray shows multiple cavitated opacities. Renal biopsy demonstrate a focal necrotizing glomerulonephritis with crescent formation. What kind of glomerulonephritis has crescents? You all must be knowing this is your RPGN, rapidly progressive glomerulonephritis. Wow. Amazing. Which of the following is not true about the condition? So first thing is, you need to find out that what is the Can you please tell me what is? Okay. Yes, Pratibha. Pratibha, you are absolutely right. Medico, you are absolutely right. Amazing. So you people are right here that it is your vaginous. In vaginous, we have C and K, not P and K. So let's see. And vaginous, it will be involving your skin, causing purpura, kidney, causing RPGN, rapidly progressive glomerulonephritis, and our respiratory tract, causing the upper and lower respiratory symptoms. Okay. So gum bleeds, your hemoptysis, all this can happen. Necrotizing granuloma of the upper and lower respiratory tract, it is correct. Granulomas involving the small size blood vessels, yeah, absolutely correct. P ANCAs will not be seen on immunofluorescence, yeah. Which kind of ANCA we are getting here is cytoplasmic ANCAs. So P ANCA will not be seen. So all these three statements are right. So they cannot be the answer, because what I need to find out here, I need to find out the false statement. So the correct answer is D. The correct answer is D, guys. Yeah. You need to find out the false statement, guys. So yeah, Max, yeah, Alka, Yamini, Naveen, Mukesh. You're right. The correct answer is D. Question number 22. Mr. N, a chronic alcoholic patient with complaints of nausea, vomiting, yellowing of skin, and ascites came to the OPD. So whenever we are talking about, any kind of disease where we have nausea, vomiting, yellow, jaundice ho raha beta, liver involvement hoga. In the OPD, when the person came, he was complaining of all that. Liver biopsy shows hepatocyte with eosinophilic inclusions with the inflammatory background as shown in the image below. So this is a liver biopsy we are taking. The patient is a chronic alcoholic. The patient is having inflammation inside. That means the patient is suffering from alcoholic hepatitis. Now, what exactly are these pink color inclusions which are happening inside the hepatocyte? Chronic alcoholic hepatitis. I have told you multiple times, eosinophilic matlab pinkish inclusion inside. This is your Mallory Denk bodies. Alcoholic hepatitis के साथ बेटा ये होता है Mallory Denk bodies. And Mallory Denk bodies, they are made up of what? This is not amyloid. This is not calcium deposit. This is not collagen. Collagen would be seen in the next state, when this person will be going into an alcoholic cirrhosis or a Lennox cirrhosis. Then you will see collagen. But we have taken the biopsy when the patient is in alcoholic hepatitis. So collagen cannot be the answer. Calcium is not there. Amyloid is not. This is not amyloid. This is an eosinophilic inclusion inside the hepatocyte, which we call as Mallory Denk, and they are made up of intermediate filaments. Okay. So the answer is A. Yes. You people are giving even this answer also right. I'm so proud of you. 23rd. Mr. O, a 50-year-old male, known diabetic from past 7 years, presented with blurring of vision. Urine examination showed proteinuria. Fundus examination shows dot and blot hemorrhages, microaneurysm, and cottonwool spots. So this is suffering from diabetic retinopathy. And even, diabetic nephropathy is also there, because proteinuria has already started. HP of glomerulus shows the following. Your diagnosis. What is the most characteristic feature of a diabetic nephropathy? This is your Kimmel-Stein-Wilson nodule. This is also called as nodular glomerulosclerosis or glomerulonephritis, right? If I ask you what is the most common finding with diabetic nephropathy, this is the patient of diabetic nephropathy, right? So the most common finding is glomerular basement membrane thickening. This is the earliest finding. I'm very sorry. The earliest finding is glomerular basement membrane thickening. The most common finding is somebody asks you, this is your diffuse glomerulosclerosis. And when somebody is talking about a most characteristic finding, then it is going to be nodular glomerulosclerosis, which is your Kimmel-Stein-Wilson lesion. Okay, so This was also a very favorite question of the examiner, that when glomerulus is getting involved in diabetic nephropathy, what it is called as. So most characteristically, it is your nodular glomerulosclerosis. When we are talking about the kidney involvement in, let's say a DCT involvement in diabetes, it will give you hyperkalemia, acidosis. When we are saying PCT involvement in diabetic nephropathy, it can cause Armani-Abstin lesion. But when we are talking about a glomerulus involvement in the diabetic nephropathy, the most characteristic finding, always remember, nodular glomerulosclerosis. Mr. P. Okay. Mr. P, 64-year-old chronic smoker, came to the OPD with complaints of difficulty in breathing. A mass has been noted on further evaluation. Difficulty in breathing. Mass has been noted on further evaluation inside the lungs. Biopsy from the mass revealed cells with salt and pepper chromatin. These cells were positive for synaptophysin. Okay, comment on the diagnosis. But once you see the options, they are talking about a lung cancer. Now, if you talk about a lung cancer, I hope you remember. Nice. So, there are 4 types of lung cancers which are malignant: your squamous, your adeno, your small cell, and your large cell. And when we are talking about a squamous cell, this is for cytokeratin. When we are talking about small cell, this is for napsin. Adenocarcinoma is for napsin. When we are talking about a small cell is positive for synaptophysin or chromogranin. There are 2 stains, synaptophysin and chromogranin. Any kind of neuroendocrine tumor will be positive for these stains. And small cell carcinoma lung, it is coming from the neuroendocrine cells which are there inside the bronchus. So the correct answer for this question is small cell carcinoma lungs. Last question for the clinical point. Miss Q, 23-year-old, presented with complaints of joint pain, hematuria, and burning sensations over the face with exposure to light. Okay, so burning sensation over the face with exposure to light, joint pain is there. On further analysis, she also complains of severe massive hair fall. So alopecia is also happening. On IHC, ANA and anti-dsDNA antibody came positive. All are true regarding the patient except. First thing, I want to know the answer for, what is the diagnosis of this patient? What is the diagnosis of this patient? Sweta, you are right. Soel, you are right. Very good. The answers which you are giving. Let's see. Yeah, Naman, Vasudev, Aishwarya, Ashok. Nice. Wow. So this patient is suffering from SLE. Now let's see. dsDNA is the most characteristic finding. Yeah. You need to find out the false statement here. So this statement is true. Most common cause of death in the patient of SLE is renal failure. No. It is not renal failure, which is the most common cause of death in the patients of SLE. In the patients of SLE, in the initial stages of the infection of this disease, the infections are the most common cause. In the later stages, because it's an autoimmune disease, so the vessels are also getting damaged, atherosclerosis is the most common cause. Renal failure? No. So this is not a true statement. Not a true statement, it's a false statement. When one statement is false, this cannot be the answer, this cannot be the answer. All are true to ho hi nahi sakta. It's a type 3 hypersensitivity. Yeah, SLE is a type 3 hypersensitivity. So this cannot be the answer again, because you need to find out the false statement. What is the answer here? The answer will be the most common cause of death is renal failure. No, it is atherosclerosis, which is the most common cause of renal failure in the later stages. Infections in the... Yeah. Yes. Koi baat nahi, Sohel. It's okay. It's okay. We are humans. We are bound to make mistakes, यार. कोई टेंशन नहीं है. ध्यान से सोचना है ना. मैंने बोला सोचो, ठीक है? So these are some clinical questions. First of all, I want to clap for you people for sticking to it and trying the answers. These are all clinical questions, not a single liners we did. Now there are some spotters which I have put for you. Now answer me. What is this cell you think? What is this cell? Is it a lymphocyte, or rod, Russell cell, or a phagocyte? Tell me. Shweta, that's good. That's good to hear. Okay. Yeah. Yeah. Now you people are coming up. This is or rod. This is not a lymphocyte. This is not a Russell cell. Lymphocyte will not have. Do you see these cylinders? Do you see these cylinder-like things inside? This is a myeloblast, which is containing rod-like cylinders inside. This is your or rod. The correct answer is B. It's not Russell cell. This is not a phagocyte. Yes. Tell me the correct answer for this. I'm waiting for this answer, man. Come on, come on. Yeah, Suresh. These are seen with AML, but we are talking about now this. Tell me. Yeah, Suresh, you are right. This all rods are seen with AML M3. Very good, Nishta. Very good. Wow. Amazing. Amazing. These are your Mott cells. This is a plasma cell. Can you see one side push nucleus, eccentric cell? This is your Mott cell. This is a plasma cell which is containing this M protein deposition as a vacuole inside. This is your Mott cell. Guys, do you know what is a faggot cell? Can anybody tell me? Can you please write? Yeah, the C is the correct answer. You're right. But can anybody tell me that what is a faggot cell? ये क्या है? Faggot cell. C is right. Yeah, C is right. You're right. Yes, Swarna, it is seen in multiple myeloma, the Mott cell. But ये जो faggot cell है ना, faggot cell is also called as okay. These are also called as or rods. Okay, or rods sometimes are also called as faggot cells. So do not confuse them. Okay. Now, what is this? What is this particular cell? There are two nuclear lobes I am seeing, and it is filled with something inside. It's having some kind of granules which are like pinkish in color. So can you please let me know what kind of cells they are? बताया अशोक, बताया. So yeah, absolutely, these are your eosinophils. This is a normal WBC, your eosinophil. This is not an RS cell. Do not confuse it because it has got two nuclear lobes. तो आपको कभी लगे ये RS cell है, आंवला appearance होता है बेटा, and it's a big cell, very big cell. This is not Russell. This is not Mott. This is your eosinophil. Now read these lines, okay? I don't think that people realize how much strength it takes to pull yourself out of a dark place mentally. So if you have done that today, or you are, or on any day, I'm proud of you. The kind of responses you are giving me on these answers, on these chat box, I don't know, as I've said before, I don't know that how you take it for yourself. But for me, it's like in everybody at MIST. I mean, we people, when we see you giving these kind of questions, I know that many of you must have thought, ये पैथो नहीं होने वाली है, ये question solve नहीं होंगे. But you are giving the answers, guys. And these are not single liners. These are hardcore clinical questions which are coming, and they're not straight questions also. True, false, match the following, all the things you are doing. Do you think how you were able to do that? Because from the last 3.5, 4 months, you people continuously are working hard. You might laugh. That's why we wasted this much time. We are humans, man. We waste time. That's okay. We would waste time. But then still, see yourself that what are you doing? You're marking the answer right. You're sitting here, you're trying. How many of you have ever thought that you'll be sitting on YouTube and watching a class? No, We went to the YouTube to see songs of Badshah. And these songs, that song, these movies. You are sitting here, you are studying, man. That's you who have done it. Be proud of yourself. Because we people, we are proud of you. And we know that you're going to crack this exam. Just keep fighting. Okay? Okay, tell me this cell. Waiting for the answers. This cell. Yes, Shivam. सब पास होंगे, सब. अपन मिलके फोड़ेंगे इसको ना, चार को. Tell me. Tell me the answer for this. Now, this, is it a hairy cell? Or is it a promyeloblast? Or is it a smudge cell? Or it's a, oh wow. Wow, man, wow. It's not a hairy cell. This, you see, cell पिचक गया बेटा, सब कुछ बाहर निकला है, कीचड़ जैसा हो गया ये. It's smudge cell. You are right. Thumbs up. You are not, you don't want anything. You're seeing the image and you know the answer. That's how well prepared you people are. Be brave. Okay, tell me this. See the options. I'm talking about the leukemias here, okay? So tell me, which leukemia can give you this kind of picture? Tell me. Yo. Yes. Tell me which leukemia can give me this kind of picture. हाँ अल्ताफ, तेरी बात सुन रहा हूं मैं. बता बेटा क्या क्या बोल रहा है. Oh yes, 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 yes. Very good. This is what? This is your garden party appearance. This is your college girl appearance. Seen with which kind of leukemia? Chronic myeloid leukemia. So the correct answer is A. Chronic myeloid leukemia. See these cells. Yeah. Absolutely. Correct. Now tell me, what are these? Are these ring sideroblasts or reticulocytes, or it is basophilic stippling, or they are gallbladder inclusions? Yes. Yeah, you are right. Yeah. Very good, Altaf. Very good. Wow. Wow. Nice. Beta, you're right. This is your golf ball inclusions. See, it looks like a golf ball. Beta, this is not a ring sideroblast. Why we are not saying it's a ring sideroblast? Because ring sideroblast, beta, it will not be blue. This is entirely blue, right? This blue smear. You're not getting that typical, pearl stain mein kya hota hai? Only iron becomes blue. The rest things are normal pinkish, the cellular content, but here everything is blue. So this is supravital stain which we have done. Okay. So this is your gallbladder inclusion. Kahan dikhta hai? Alpha thalassemia. How many genes deletion? 3 genes deletion. Which disease? Which kind of hemoglobin you will get? HbH hemoglobin. And that is why it is called as HbH disease. Hanji. Tell me, is it OR rod inside the AML? Or is it a myeloblast? Or is it a hypersegmented neutrophil seen in a macrocytic anemia? Or is it a Dutcher cell in multiple myeloma? Yes, HbH, you are right. You are right. You are right. Yo. Yes, this is a hypersegmented neutrophil, guys. This is a hypersegmented. See the nuclear lobes. 1, 2, 3, 4, 5, 6. So there is hypersegmentation of the nucleus here in the. What are the normal nuclear lobes of a neutrophil? 3 to 5. But you are getting, more than 6 or more than 6. You call it as hypersegmented neutrophil. This is a normal small lymphocyte. And see the size of the RBCs also. These RBCs are bigger in size. So it's a macrocytic anemia. And this is your hypersegmented neutrophil. So you people have given the right answer. Once again, thumbs up. So it is your C. Then next. Okay. Simple. You see this is the schistocyte. The cells. the cells which are like this, what are these cells? Are they schistocytes, or they are dacrocytes, which are called as teardrop RBCs, or they are crenated RBCs, or they are pencil cells? Pencil cells. Yes, Yadav. Yes, Akhtar. Oh, wow. Yo, yes. This is the characteristic finding which we are seeing when we are talking about that it is your iron deficiency anemia which we have. In the iron deficiency anemia, we have a numerous amount of anisopoikilocytosis. That means all the RBCs are of different shapes and sizes. Okay. And you are getting a very characteristic RBC finding in iron deficiency anemia, and that's going to be RBCs becoming slender. They're becoming like a pencil. So it is your pencil cells. Okay. Yeah, tell me this cell. This cell, yeah, idea. You are right, you are right, you are right. Now please tell me this cell. What is this cell, guys? Yes, there are. No, beta. Jacob, they are not helmet cells. No. Yeah, Shoaib, you're right. Oh my God, thank you. I just cannot read the names now. There's so much of answers coming. Very good. They're your target cells. They're your target cells. They're again not schistocytes, dacrocytes, or a reticulocyte. This is the target cell. Why we call it as? Because it looks like a target. You know, the dart game we play. Why this is happening? Because the RBC membrane is stretched from here, so more hemoglobin goes inside that membrane, and it gives it a central, color like a target. So seen with thalassemias, sickle cell anemias rather, in that also. What are these cells? Now let's come to this. A very important cell, where you are seeing something getting deposited over like this, these dots. What kind of cells they are? Are they a reticulocyte? Or they are Cura bodies? Or it's an Heinz body? Or it's a target cell? So target cell to abhi dekha hai beta, to wo to ho nahi sakta. So D cannot be the answer. So tell me, out of A, B and C, out of A, B and C, what are the cells? Very good. Very good. They're your Heinz bodies. You have hemoglobin getting precipitated. Hemoglobin getting precipitated over the RBC membrane like that. And they are seen with G6PD deficiency anemia. What are these cells? The Chokopai cells. What are these cells called as? Are they smudge cells? Are they dacrocytes? The teardrop cells? Or are they Heinz bodies? Or they are bite cells? Yeah, absolutely. G6PD. Correct. Correct. Amazing. They are your bite cells. D is the correct answer for these questions. Again, you see RBC, which is having a dot inside like this. This is an RBC containing dot inside. Are they Heinz body? No. Heinz body will have something getting deposited over the RBC membrane like a ring. It will look, okay, a diamond ring kind of a thing, and it will be stained by supravital stain. So ये normal stain है, तो ये Heinz body नहीं है. Platelet over the RBC? No, it is not like that. Target cells have a central pallor. Even in target cells, we have central color. So they cannot be target cell. They're Howell-Jolly body. In Howell-Jolly body, you have a remnant of DNA inside the RBC, which is accumulated like this. Denatured chromatin material is there here. So this is your Howell-Jolly body. Okay. This, please tell me. You are right. You are right, Guru. All of you. What is this cell? Is it a sickle cell RBC? Or is it a myeloblast? Or is it a lymphocyte? Or is it a monocyte we have? Yes. Siddharam, very good. Jacob, positive vibes. Vasu. Yeah, okay. So now I can, so many of you, very good. It's a monocyte, okay? So you can see the kink in the nucleus, a bean-shaped nucleus. This is a monocyte for you. The correct answer will be D. Then this, what are you seeing here? This is the biopsy which have been taken. See, in the exam, they will give you definitely some history, but I know that you people are well prepared. You will see this image, you will see the options, you'll understand, okay, they're talking about brain tumor. And which brain tumor has got these kind of findings like this? Can you please tell me which kind of tumor has got this kind of a finding where you have this concentric kind of a thing inside? So yeah, Afzal, very good, guys, very good. These are your samoma bodies which are seen with meningioma. The correct answer is A here. So you see, you don't even understand, you don't need the history here. You know that much. So be confident in yourself, man. You say, sir, याद नहीं रह रहा, कुछ भी याद नहीं रहता हमको, हम सब भूल जाते हैं. We have studied something 3 days back and now we have not remembered. Beta, you studied pathology, I don't know when, but still you just see the image and you're giving me the answer. So be positive about it, sir. Be confident, yeah. This we have discussed in a question, so you already know the answer for this question. जल्दी से फटाफट बताओ. Beta, medulloblastoma will not show samoma body. Medulloblastoma will give you Homer-right rosettes. Medulloblastoma never gives you samoma body. Samoma bodies, they are with meningiomas, okay? Okay, yeah. Anandita, very good. Vasu, soil, oh my God. Yeah, so absolutely. Yeah, you are right. This is schwannoma. You have antennae A here. You have antennae B, the hypocellular area, and in between the acellular area, this is your Verocche bodies. Exact exam question of yours. The image has come in your exam. So, what is it? Is it a tumor of the vessel, the hemangiomas, or is it a keloid, or is it a proud flesh, or is it a hypertrophic scar? So I'm waiting for the answer for this question. First thing, try to see the site. It is where? It is somewhere here. Okay, so the examiner is giving you, yeah. Very good. Amazing. It's keloid. It's a keloid. The most common site for keloid is sternum. It is coming over the wound and it is going beyond that as well. So it is your keloid. Keloid matlab Ravan, which is a raised scar even outside the wound boundaries. What is this? See the options. In the options, we are talking about already the pigments, okay? So see it. Where is the pigment? This is the nucleus, around the nucleus. So obviously the pigment which we have is around the nucleus. What is the pigment which we have around the nucleus? Oh, around the nucleus, beta. Yes, you are right. Very good. Now you are coming to this question. Thank you very much. This is your lipofuscin. The perinuclear pigment we have. Perinuclear. Tell me, if just this image is there, let's see, if you just have this image, what will be your answer? Is it trisomy 22? Is it trisomy 18, the Edwards? Is it trisomy 13, the Pataus? Or is it a trisomy 21, which is Downs? Tell me. Tell me, guys. Which kind of trisomy is it? Is it trisomy 22, 18, 13 or 21? Ye hoti hai na baat yaar. Ye, you just get the image, you see what? ठीक है, trisomy तो है. What are you getting here? The prominent occiput. Once you see a prominent occiput, तुमको पता है यार, prominent occiput आया ना, तो अपने को ना Edward के बारे में सोचना है. ठीक है? So this is your Edward syndrome. This is your trisomy 18. Then, बताओ यार, ये क्या है? What is this cell? These are the RBCs you are getting. Is it a lymphocyte which we have? Or is it a myeloblast? Or is it a plasma cell? Or is it a monocyte? तो मोनोसाइट तो तुमको पता है नहीं हो सकता. ठीक है, लिम्फोब्लास्ट के लिए यस ट्राइसोमी 18. बेटा नहीं राहुल, 13 नहीं होगा बेटा, 18 होगा. हाँ, ये वाला क्वेश्चन बताओ बेटा. टेल मी दिस क्वेश्चन. बेटा नहीं, इट इज नॉट अ माइलोब्लास्ट. देखो आप, Why am I saying it's not a myeloblast? Beta, whenever we are talking, listen to me carefully here. Whenever we are talking about a blast, blast में beta, blast is an immature cell, a tumor cell. तो nucleus कैसा होना चाहिए? In a lymphoblast and a myeloblast, both have big nucleuses. आप देखो, it has so much of cytoplasm. And nucleus is not as big as it should be if it's a blast. And secondly, beta, nucleus is shifted to one side, right? It is shifted to one side. Do you see any nucleoli inside? No, you're not seeing any nucleoli. So how can it be a myeloblast? Myeloblast has got nucleus, nucleoli, abundant cytoplasm is there, vacuoles are there, I understand, but the nucleus has to be very big. But the nucleus is not very big. You have an eccentric nucleus in this. This question, yeah, now you are right. This question, the answer is plasma cell. Okay. Recent exam question. What is this? Tell me. Now you are right. Yeah. Soil, beta, it totally depends upon that what they are asking. Russell cell, they are modification of a plasma cell only. So if they are giving you a plasma cell as the option and a Russell cell as the option, you are talking about this question. So if they are asking you Russell cell automatically is their abnormal plasma cell only, no? So they will not give you abnormal plasma cell and normal plasma cell to differentiate a bit in between. No, they won't be giving you. What is Russell? Russell, Mott, Dutcher, Flame, all these are modifications of a plasma cell. They are abnormal plasma cell which we see in multiple myeloma. So you're right. It looks like Russell because we have deposition of something inside the cytoplasm, but then it's a plasma cell. That's what we are more. Yeah, very good. So you know the answer. You're giving me the answer, obviously. This is your asbestos body. This is your asbestos dust superimposed by some proteins over it. This is also called as ferruginous body. It cannot be anthracotic pigment because it has to be black in color. Charcot-laden crystal, no, it is eosinophilic, very pinkish. Artifact, no, this is your asbestos body. Okay, A is the correct answer. Then this technique, please let me know what is this technique. If anything of this sort comes, you already know, you've already started giving the answers as well for this. Is it a PCR or the FISH or enzyme immunoassay or a Doppler? Yeah, yes, so yeah, it is FISH, correct, it is FISH. Then this cell, what is this cell? Again, the nucleus is going on one side, okay, and we are seeing some, some kind of deposits which is going out like this. Is it a monocyte? No. Is it a myeloblast? No, myeloblast will have again a big nucleus, so do not get confused over it. What is it? Is it a flame cell or a hairy cell? Yeah, you are right. You are right. It's a flame cell. It's a flame cell. A flame cell. You see the deposition making it like a flame. When we say about a hairy cell, this is a hairy cell. So try to see the difference between hairy cell will have cytoplasmic projections which are like this. These are cytoplasmic projections which you are seeing. This is your hairy cell, beta. This here is a flame cell, and this here, I'm telling you the answer myself, this is a hairy cell, because some of you get confused. That is why, and I knew that, you might get confused. That's why the next slide I kept was a hairy cell. Okay. Then some more images. What is this? This is your number one. This is number one, this is number two. Tell me, what is number one and two? First is, this is a supravital stain. This thing, it contains some nuclear remnant inside. So this is a reticulocyte, right? And this is a normal RBC because it does not contain anything. So what is first? Our normal RBC. Yeah, yes. So first is a normal RBC and second thing is a reticulocyte, supravital stain we have. So the correct answer is B in this question, B. First is the RBC and the second is a reticulocyte. Okay, these are not golf bodies. This is not an Howell Jolly body we have, and this is not Heinz body also. Heinz body will have deposition over it, right? So this is not a Heinz body. Last two questions. Solve this pedigree. Is it an autosomal dominant or a mitochondrial inheritance or gonadal mosaicism, or it's an X-linked dominant disorder? Let's solve this. So whenever you are solving a pedigree, first thing you have to see the options. In the options, if you are getting a non-Mendelian disorder, you need to think about it first. What is mitochondrial inheritance? Only mothers transmitting. What is gonadal mosaicism? Parents are absolutely normal, but the progeny is affected. When we are talking about a Mendelian disorder, it could be autosomal dominant, recessive, X-linked dominant, X-linked recessive. So we are having the non-Mendelian, so we need to rule out these first. I'm giving you a knack of solving this question. Whenever we are talking about, let's say you get an option in which you have a non-Mendelian disorder. So whenever you need to find out, when you need to solve the non-Mendelian pedigree, let's say you are thinking it's a non-Mendelian pedigree. So you need to understand one thing. If you are seeing child of any parents, these are the probabilities of the child of these, right? And if you see that all the four are getting affected like this, these couple, they have 3 childs and all of them are affected. That means it cannot be Mendelian. Because Mendelian law has got a law of probability that these much will be affected, 20% affected, 25, 50, 75, like that. But here all are getting affected. So whenever you see this kind of a situation, always think about being it a non-Mendelian disorder. And in the non-Mendelian disorder, on a pedigree analysis, you will only be able to solve only these two. The mitochondrial inheritance and gonadal mosaicism. अब mitochondrial में क्या होता है? सिर्फ मम्मी ट्रांसफर करती है, पापा ट्रांसफर करते ही नहीं है. तो देख लेते हैं पहले ये है कि नहीं. मम्मी, mother has transmitted the disorder to all the 5 child this couple had. Wow. Here father is there, didn't transfer, but mother infected, transferred to all. Father is there, didn't transfer, mother infected, transferred to all. And again, father doesn't transmit to anyone. So obviously, who is transmitting the disease? All the progenies are getting affected here. So this has to be a non-Mendelian. And in non-Mendelian also, all the parents, everywhere the parent is affected. So it cannot be gonadal mosaicism. What we are left with? We are left with mitochondrial inheritance. Okay. And yeah, yes. Now this one, the last question. Autosomal dominant, mitochondrial inheritance, gonadal mosaicism, or X-linked dominant, X-linked recessive. So let's see. We have these two. We need to find out this. But here, if you see, it can be, but only mother transmitting, it's mitochondrial. So mother transmitted here, okay. But mother didn't transmit to all. There are how many children? 1, 2, 3, 4 probabilities they have shown. 1, 2, and 3. So all these 3 are not affected. Only 2 are affected. So that means it won't be non-Mendelian. It will be Mendelian. So B and C automatically cuts out. Now we are talking about A and D. When you have to differentiate between dominant and recessive, the first thing you have to do is you have to count the generations, and you have to see that every generation has to be involved. So this is third generation involved. Second generation also we have an involvement. In the first generation also we have an involvement. It can be dominant. And if it is dominant, you need to find out one more thing. And that one more thing is going to be that whatever the child is infected, that affected child should have one of the parent affected. So if this is affected, parent affected. These are the childs affected, parent affected. These are the child affected here and the parent is affected. So it has to be a dominant. And what choice do we have in dominant? Only autosomal dominant. So this is going to be the answer here. Okay, the answer is A. So you have already, yeah. So you have already given me the answer. Yes, guys. Yes. Amazing. Now, these were some 25 clinical questions which I wanted to show. Some images also I have given you. I don't know what I can see from here, that majority of you, no skipping of generation. Absolutely. These some single liners. Starry sky appearance. Guys, starry sky appearance is seen with which kind of glomerulonephritis? You already know this, it is PSGN. Then if we are talking about a tram track appearance, which is seen with which kind of glomerulonephritis? Tram track. Shweta, thank you very much. Still, we have little left. Tram track appearance. We are talking about only glomerulonephritis, okay? This is going to be seen with MPGN. Now, crescents, when we are talking about crescents, they're half moon shaped structures. And you are right, yes, it is going to be rapidly progressive glomerulonephritis. HIV associated glomerulonephritis, which is seen in old people, the adults. Yes, this is going to be FSGS, focal segmental glomerulosclerosis. Loss of food process of podocytes. Yes, very good. Loss of food process of podocyte. This is your minimal change disease. Most common cause of nephrotic syndrome in a child. Spike dome. Spike dome. Yeah, Adil, you are right. Himanshu, you are right. Very good, guys. This is your MGN, membranous glomerulonephritis. Nice. Kimmelstein-Wilson lesion, we have discussed. You already must be knowing the answer. Yeah, membranous it is. This is your diabetic nephropathy. Diabetic nephropathy. And most common cause of recurrent hematuria. If they have just given you this answer, this question, most common cause of recurrent hematuria, it is always IgA nephropathy. This is IgA nephropathy which we have. Okay. Then this is, every exam from last 3-4 times contained this question, medical exam. Please tell me what will be the iron levels in the patient of iron deficiency anemia. In the iron deficiency anemia, we have learned one thing, and that one thing is that everything decreases in iron deficiency anemia except one thing, and that one thing would be, give me the answer for one thing which is gonna be decreasing in one thing which is going to be increasing in iron deficiency anemia, and that is, yeah, you are right. What increases in iron deficiency anemia, guys? Very good, Himanshu, very good. Everything decreases except TIBC. It increases. When we are talking about anemia of chronic disease, in anemia of chronic disease, it is same as iron deficiency anemia, where in the iron department and saturation department. But where it is reversed, the reversal is seen between ferritin and TIBC, because what is the pathogenesis of anemia of chronic disease? In anemia of chronic disease, the iron is not able to transport in the blood. There is no deficiency of the iron, but the transport is the problem. That is why the iron is more, but TIBC is less. Okay, because ferritin and TIBC, they are inversely proportional to each other. And sideroblastic anemia, excess iron, man. This is excess iron, because the iron is not able to be utilized by the body in formation of heme, because we are not having protoporphyrin because of the deficiency of vitamin B6. So in sideroblastic anemia, it is going to be exactly opposite of IDA. So what it is going to be? Iron high, ferritin high, saturation more, but capacity low. These three things I want you to by heart before you go for the examination. Okay. Now, read these lines for yourself. Now, in this, I'm ending the session here. It's been long. I wanted to finish it quickly, but it took a little while. Make sure you're in the final phase of your preparation. Things from here on till 4th, they're not going to go easy. The weights which you're carrying on your shoulders right now, the pressure which you have inside you right now, it's not getting any lighter. If somebody says the situation is going to be easy after 5 days, no, it won't be. It won't be more tougher. When you'll have, 21st, 22nd, 23rd, 24th of November, you will be having this pounding heart, because things are going to be tough. The road which you have to walk on that road. It is not getting any shorter. And the work which you have to do, you just promised me that you're going to work 200%, right? So it is not getting easier. But then you are getting stronger, guys, mentally. You are here sitting with me from last 2 hours and giving the answers. Can you understand the mental toughness you people are having right now? That's what we wanted. That's what we are getting. You're going to win this. You're going to win this. Just keep doing it. Just give your 200%. Make a promise today that whatever time I'm left with, it's going to be tough. Yes, it's going to be tough. Nobody said it's going to be easy. But when you'll get the result, when you go inside that examination hall on 4th of December, and when you'll come out, and when you have that smile on your face, a little smile that, okay, whatever I read, it came. And I was able to complete it. I was able to mark it. That satisfaction, and the time you'll have the result, that happiness on your face. We all love our parents, right? I wish that you are seeing the result in front of your parents. And when you'll tell them that, Papa, मैं pass हो गया, Mummy, मैं निकल गई, हो गया मेरा. Better the sheer joy they will have, you'll be fortunate enough to see that smile on their face. That day, whatever bad you have done in life, that's over. Okay, so this is real, guys. 4th ko we have to go in the exam, but we are prepared. We are preparing ourselves. We should be proud of ourselves that we are doing it. Okay, so be strong, have strong will, and keep working hard. Okay, we from the entire team missed you. I mean, I salute you people. We all salute you for your hard work, for your dedication, and we wish you good luck for your exam on 4th. मेहनत करते रहना बेटा, करते रहना मेहनत, ठीक है? So we'll see you on the other side. We are waiting for your success, and just keep working hard. Result क्या होगा छोड़ो उसको, but keep working hard. May all you pass this exam. Thank you very much for being with me here, and I hope this session gives you some positive energy and it helps you during your exam. Thank you very much. Thank you very much. Thank you, guys. Thank you very much. Take care. Bye-bye. I'll share the PDF. Don't worry about the PDF. We'll share the PDF in the description. I'll share the PDFs. You'll get the PDF. You can come back to the video and download it. Thank you very much. Bye-bye. Take care.